بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, we will continue the talk about the aortic lesions, and we'll also discuss the remaining part of the issues dealing with the aortic aneurysm. And in this lecture, we are going, inshallah, to discuss these issues. Number one is the aortic aneurysm complications, including rupture, aortocaval fistula, aortoenteric fistula, then traumatic injuries to the aorta, then inflammatory aortitis, including Takayasu, giant cell arthritis, chronic periaortitis, and IgG-related periaortitis. Then we'll discuss the issue of inflammatory abdominal aortic aneurysm, retrobritonial fibrosis, and the peripheral arterial diseases. Then we'll finally discuss the traumatic peripheral arterial injuries, including the pseudoaneurysm and the arteriovenous fistula. You remember from the previous lecture that there are certain criteria to diagnose the aortic aneurysm, and there are some issues to be fulfilled in the radiology report, which are very important for the surgeon. Now, what are the complications of the aortic aneurysm? Actually, there are three. Number one is the mass effect, which is related to the size of the aneurysm, then the possibility of dissection, and the possibility of rupture. The complications are usually related to the size, and this is according to the literature. The rate of dilatation of thoracic aortic aneurysm per year is about 0.12 centimeter per year. Then the risk of complications is high if the aneurysmal size is about 6 centimeter for the ascending and 7 centimeter for the descending aorta. The annual risk of rupture, dissection, or death for thoracic aortic aneurysm that is more than 6 centimeter in diameter is about 14%. And this will increase to 20% if the diameter is more than 7 centimeter. And according to the literature, there is a marked increase in the risk of complications for aneurysms that are larger than 5.5 centimeter. And you can see this is a huge abdominal aortic aneurysm, which is causing bulging of the abdominal contour. And you can imagine what happens if this patient had a minor trauma to the anterior abdominal wall. Then the aneurysms less than 4 centimeter in diameter, the risk of complications is about 0%. And this risk is about 50% for aneurysms that are 8 centimeter in diameter or greater. Of course, there are two important risk factors for patients with abdominal or with aortic aneurysm. These are the smoking and the uncontrolled hypertension. Then if a patient had an aortic aneurysm and he is one of the smokers and he is also male, then you should screen this aortic aneurysm by ultrasound every year to assess for the size progression of the aneurysm. And sometimes you may need a shorter follow-up times, especially by CT angiography, for aneurysms that are more than 45 millimeter in diameter. The symptoms of an aneurysm are usually non-specific, and some aneurysms, as I have mentioned, may produce symptoms by pressure or due to dissection or rupture. Then the symptomatic aneurysms are at high risk of rupture compared to the asymptomatic aneurysms. And there are two lines for treatment of aortic aneurysms. These are surgery and endovascular repair. There are many signs for the to say that this aortic aneurysm is about to rupture. Number one is enlargement in the size, which is more than usual. Then focal discontinuity of the calcification of the wall of the aneurysm, or hyperattenuating crescent sign, which indicates an intramural hematoma, or fissures in the thrombus if the aneurysm is partially thrombosed. Then the drabbed aorta sign or periaortic stranding, as I will show to you. These signs are not highly specific, but indicates that we need urgent management. Then in the CT scan, you can see actual signs of rupture, including active contrast extravasation and high attenuation hemorrhagic collection in the pleura or the peritoneum or the mediastinum. And they also said that the rupture of the abdominal aortic aneurysm usually involves the posterolateral aspect of the aorta. Then these are the primary signs of impending aortic aneurysm rupture. Number one is periaortic fat stranding. As you can see here, there are reticulations of the fat surrounding the aneurysm. Contrast extravasation, which is an indication of rupture, as you can see here. Retrobritonial hematoma, as you can see also here, and this is a true sign of aortic rupture, and the development of an aortocaval fistula, which means that there is communication between the aorta and the inferior vena cava. The secondary signs are, number one, the hyperdense crescent sign. And the hyperdense crescent sign means that you got an intramural hematoma, meaning that the blood is taking its way through the aortic wall, and this is a sign of impending rupture. The drabbed aorta sign means that the aortic contour follows the contour of the adjacent dorsal of the adjacent vertebral body. The tangential calcium sign means that the calcium is pointing a little bit away from the true circumference of the aorta. Then focal discontinuity of the calcium, like then you see here, and fissures in the thrombus, like you will see just now. And this is what we call intramural hyperdense sign. And this is a sign of impending aortic rupture, because it means that you got an intramural hematoma, which will, as I have mentioned in the previous lecture, may lead to aortic rupture. And this is what we call the fissures of the thrombus, the true lumen, and this is the mural thrombus, and you got fissures inside the thrombus with extension of the blood, or let us say contrast material within the thrombus itself, and this is also one of the impending signs of rupture. You see here, this is the mural thrombus, this is the true lumen, and you got fissures that are filled with contrast material, which indicates that this aortic aneurysm is about to rupture. Then this is what we call the continuous calcium or ring sign, where the aneurysm is outlined by calcium all through its way. While here you got disruption of the calcium, which is a sign known as focal discontinuity, and also this pointing of the calcium away from the contour of the aorta. Then this is the drabbed aorta sign, where you got the posterior wall of the aneurysm following the contour of the adjacent vertebral body. And this aneurysm does not show the drabbed sign, where you got the aneurysm with the mural thrombosis, but it does not follow the contour of the vertebra, while here it follows. This sign is a sign of impending rupture. Then tangential calcium sign is that you are seeing here. Actually, you should elicit that calcium is going all around the aortic wall in, let us say, a circle. But when the aorta is the aneurysm is about to rupture, you got this appearance where calcium will not follow the contour of the aorta but extends outside the circle, and this is known as the tangential calcium sign, and can see it here and can also see it here together with, of course, the retroperitoneal hemorrhage, which is a frank evidence of aortic rupture, aneurysm rupture. This is focal discontinuity of the calcium, which is not a pathognomonic sign, since you know that calcification of the aortic wall in many patients is not a well continuous circle of calcium, but the disruption of the calcium as well as the tangential calcium sign together, and also you see here a stranding of the periaortic fat. All these signs are signs of impending aneurysm rupture. And here the follow-up study, and you can see that the aneurysm is becoming bigger by time, and this is also one of the signs that this aneurysm is about to rupture. Then we have two ways for management of the abdominal aortic aneurysm, and this will depend on the size and the location, and also the presence of some important measurements. Then, if the aneurysm is located above the level of the renal arteries or at the level of the renal arteries, then this aneurysm will be surgically repaired. But in cases of infrarenal abdominal aortic aneurysm, if these criteria are present, then we may sort to the endovascular aortic repair. If not, then you go surgery. What are the criteria? Number one, concerning the aneurysm neck. The neck length should be more than 1.5 centimeter. Calcification less than 50% of the circumference of the aneurysm, and that the neck angle is more than 150 degrees. The mural thrombosis occupying less than 50% of the aortic lumen. About the common iliac arteries, the artery diameter should be from 8 to 22 millimeter, with no excessive tortuosity, with calcification less than 50% of the circumference, and the artery length should be more than 3 centimeter. And the femoral access, where we will insert the venous line, the arterial line with this femoral access should fulfill that calcium is less than 50% of the circumference of the femoral artery. Now, what about the aortocaval fistula? This is a rare complication where the aorta is in direct continuation with the IVC. And there are two main reasons for this: trauma and a rupture aortic aneurysm into the inferior vena cava. The aneurysmal rupture and the erosion of the IVC represents about 85% of the cases, while 15% are related to the trauma, and other rare causes include neoplasms and some of the inflammatory pathologies. The patient will present with acute symptoms due to congestive heart failure, since the blood flow will be directed to the inferior vena cava. The diagnosis is easy, where you can see that there is simultaneous opacification of the aorta and the IVC in the arterial phase of the contrast enhanced CT angiography. If you go a little bit down, then you can see the direct communication between the aorta and the IVC. These are the signs: early contrast opacification of the IVC, loss of the normal fat plane between the IVC and the aorta, and the enlargement, of course, or dilatation of the IVC due to the pressure. Then you remember this case where there are some fissures in the thrombus, and there is also simultaneous opacification of the aneurysm and the IVC in the arterial phase, denoting the presence of aortocaval fistula. Also, the aneurysm may rupture through the intestine, especially the third part of the duodenum, which is a fixed retrobritonial structure. The incidence of aortoenteric fistula is about 0.05%, and the aneurysm that is rupturing inside the gut is in about 85% of the arteriosclerotic type. Then this is aortoenteric fistula is considered fatal, with a total mortality rate of about 90% according to the literature. Then aortoenteric fistula will have a triad of symptoms. Number one, gastrointestinal bleeding, abdominal pain, and pulsating abdominal mass. Then, during the CT angiography, you see that the blood stained by the injected contrast material will go into the small bowel. As you can see here, this is the aneurysm, and this is the site of rupture, or the site of the fistula between the aneurysm and the duodenum, and also you got contrast stained blood in the stomach as well. Now we came to the injuries or traumatic injuries of the aorta, and the most common site for traumatic injuries of the aorta is known as the aortic isthmus. And the isthmus is the segment of the aorta distal to the origin of the subclavian artery till the site of the ligamentum arteriosum, which is corresponding to the site of the beta ductus arteriosus. Then this part of the aorta is relatively fixed and is liable for traumatic injuries. The injuries are 4 grades: grade 1 intimal tear, grade 2 intramural hematoma, grade 3 pseudoaneurysm, and grade 4 is a frank rupture. Grade 1 is treated conservatively. Grade 2, 3, and 4 are treated surgically. Then the diagnosis relies upon the presence of luminal irregularity with intimal flap, contour irregularity with pseudoaneurysm, periaortic hematoma, contrast extravasation, or frank transection of the aorta. Then the suggestive features of traumatic aortic injury include hypotension. Then you got signs of trauma, of significant trauma, like injuries of the spine, the scapula, or the pelvis, and the presence of pulmonary contusions and hemothorax. This is thoracic trauma showing a pseudoaneurysm in the descending thoracic aorta. And if we enlarge this image, and you can see that there is a false aneurysm communicating with the aortic lumen with periaortic small leak. Then this is great for traumatic injury of the aorta with extensive blood in the mediastinum. Now we came to the aortic inflammatory lesions, and the inflammation will affect the aortic wall, and this is known as aortitis, or the affects the periaortic soft tissues, and this is known as periaortitis. And if you look carefully to the list under the both titles, and you can see that is almost the same, except for these two issues. In aortitis, the giant cell arthritis and Takayasu is one of the specific causes of aortitis, while neoplastic lesions are a specific cause for peri-aortic inflammation. But the whole list are almost the same, and you got the rheumatoid disease, sarcoid infection, systemic lupus, Erdheim-Chester disease, and so on. What I would like to say is that inflammation of the aorta, of the aortic wall, may be associated with inflammation of the periaortic soft tissue in most of the cases, except in these two conditions where you got the giant cell arthritis or the temporal arthritis and the Takayasu arthritis. Then what are the causes of aortitis? As I have mentioned before, you got Takayasu arthritis, giant cell arthritis or temporal arthritis, rheumatoid, systemic lupus, spondyloarthropathies, ankylosing spondylitis, and Reiter syndrome. Other causes of small vessel vasculitis, which are known as anti-neutrophil cytoplasmic antibody, will include Wagner granulomatosis, polyarthritis nodosa, microscopic polyangiitis. Then you know Behcet, Cogan, relapsing polychondritis, and sarcoidosis. Isolated aortitis has many other names like isolated idiopathic abdominal periaortitis, and of course you include in this group the retrobritonial fibrosis or Ormond's disease. Inflammatory abdominal aortic aneurysm will be discussed in a separate title. Then also the infectious aortitis will be discussed separately. We came to the Takayasu arthritis, which is one of the well-known types of arthritis, and it has many other names like Balcel's disease, occlusive thromboaortopathy, or Martorial syndrome. This disease primarily affects large vessels, especially the aorta and its branches, especially the subclavian arteries, and is commonly seen in young females in East Asia that are almost exclusively affected by this disease in the age of the second or the third decades of life. The interval between symptoms and the diagnosis may take about 2 to 11 years. The symptoms are non-specific. They include fever, nocturnal sweating, weight loss, joint and muscle pain. But if the artery is stenosed or occluded, you got ischemic symptoms, of course. Then the Acr criteria for the diagnosis of Takayasu should include 3 or more of these criteria in order to reach the diagnosis of Takayasu arthritis with sensitivity of 90% and the specificity approaching 100%. These criteria are the age at the disease onset should be less than 40 years. Then claudication of the extremities, muscle fatigue and discomfort, decreased pulsation of one or both brachial arteries, blood pressure difference of more than 10 millimeter mercury between arms, Berwi over the subclavian arteries or the aorta, and the CT or angiography detected stenosis of the vessels. Then the angiogram abnormalities include narrowing or occlusion of the aorta or the primary aortic branches. And this narrowing should not be due to arteriosclerosis, fibromuscular dysplasia, or similar other causes. This narrowing is due to inflammation of the aortic wall. The characteristic clinical features include weak or absent peripheral pulse, since the name pulseless disease, vascular bruit, renal hypertension due to renal artery stenosis, retinopathy and aortic valve insufficiency, dilated cardiomyopathy and myocardial ischemia in cases of involvement of the coronary arteries, syncope, seizures, and amaurosis fugax may occur as a result of cerebral ischemia. This amaurosis is a condition in which the person cannot see out of one or both eyes due to lack of the blood flow to the eye. Then the major criteria described by Ishikawa classification said that you got two major criteria, or one major and two minor criteria are enough for the diagnosis of Takayasu. The major criteria are symptoms consistent with Takayasu, as I have mentioned, lesions in the mid portion of the left or lesion in the mid portion of the right subclavian artery. The subclavian artery is considered one of the major criteria for the diagnosis of Takayasu according to Ishikawa. Then these are the minor criteria. ESR, erythrocyte sedimentation rate, around 20 millimeter per hour. Carotidemia, which means a throbbing pain of the neck and the face with tenderness over the carotid artery, and hypertension, aortic valve insufficiency. Then lesions in one of the following vessels: pulmonary artery, mid-common carotid, distal brachiocephalic, descending thoracic, abdominal arteries, coronary arteries. And the CT angiography, you can see that there is thickening of the aortic wall and enhancement of the wall. An MRI, it also shows the same criteria, but it has a relative lower spatial resolution. PET scan will show active metabolic activity in the wall of the affected artery due to the presence of inflammation. There are 5 types for arterial involvement by Takayasu. The type 1 and type 4 are the most common. And you got this type 1 affection of the aortic arch branches, and type 5 affection of the whole aorta, the ascending arch, descending, and so on. And there are variable affections in between. Then if you look here for this young female patient with MR of the chest, and obtained after injection of contrast media, and you see no, it's obtained without injection of contrast media, and you got this thickening of the wall of the origin of the branches coming from the aortic arch, the left subclavian, left common carotid, and the innominate artery. And here one of the major criteria of Takayasu, which is occlusion of the left subclavian artery, but the vertebral artery is patent, as you can see here. Also, if you do a CT angiography or a CT with contrast material, then you got this appearance, which is known as the double ring sign. The double ring sign means that there is enhancement of the outer margin of the affected segment of the aorta with an underlying hypodense non-enhancing rim. Then you can see this also in the major branches of the aortic arch. And this is multiple presentations of Takayasu. In this case, you got inflammation of the ascending and descending aortic wall, while here you got inflammation of the wall of the major branches of the aortic arch, while in this example you got inflammation of the wall of the right common carotid artery. Tachycardia also may affect the pulmonary artery, either leading to stenosis or aneurysmal formation. And both are present here with stenosis of the right pulmonary artery and aneurysmal formation of the left pulmonary artery. Now we came to the giant cell arthritis, which is known also as temporal arthritis. And this is the most common form of non-infectious arthritis. And the aorta is affected in a minor group in this particular disease. And it is also common in females, but over the age of 50. And the prevalence increases with increase in the age. The symptoms include headache and impaired vision due to vasculopathy of the vascular supply to the optic nerve. And jaw claudication is considered one of the pathognomonic features of this particular disease. Fever, muscle pain, weight loss, cranial nerve deficits, and double vision are rare. Temporal swelling along the temporal artery with tenderness is clinically striking. And you see this appearance, and also you may, if you put your hand and you got significant tenderness over the site of the artery. Then elevated erythrocyte sedimentation rate and C-reactive protein are also present in this disease. The Acr criteria for diagnosis of temporal arthritis or giant cell arthritis, you need 3 or more criteria consistent with the diagnosis of giant cell arthritis with a sensitivity of 95 and the specificity of 90%. These are the criteria. Number 1, age of the disease around or more than 50 years. The positive response to steroids within 2 days, history of illness more than 2 weeks, new headache or new onset of localized pain in the head, temporal artery tenderness or pulsations unrelated to arteriosclerosis, elevation of the erythrocyte sedimentation rate, and the biopsy, which is characteristic or characterized by the predominance of mononuclear cell infiltration, granulomatous inflammation, multinucleated giant cells. And this is the pathology of the development of temporal arthritis or giant cell arthritis, if anyone would like to know. Then we came to the diagnostic criteria. Of course, you may have the ultrasound and Doppler. You may also diagnose it by contrast enhanced CT. The role of PET scan will is to see the inflammation of the arterial wall by the metabolic activity. Then by Doppler, you got what is known as the halo sign. And this halo sign surrounds the aortic, the vascular lumen because of the inflammation. And this is one of the criteria. Also in CT angiography, you got inflammation around the aorta. And then you may ask that how can I separate this appearance from the previously mentioned appearance of Takayasu? The answer is that this patient should have a clinical diagnosis or histopathologic diagnosis of giant cell arthritis in order to say that this aortitis is due to giant cell arthritis. Actually, if you do not have these informations, then you say that this is peri-aortic or aortic wall inflammation, and you mention the differential diagnosis, and you say that this may be due to Takayasu and may be due to giant cell arthritis. And if you remember that in Takayasu arthritis, and you got the double ring sign, which is not present here. Also, in giant cell arthritis, you may the aorta may be involved by aneurysms, and these aneurysms may be multiple, as you can see in this particular case, and you have two aneurysms arising from the aortic arch. The inflammatory lesions of the aortic wall is known as aortitis, and it typically involves the infrarenal abdominal aorta, and this inflammation may be limited to the aortic wall or accompanied by changes adjacent to the aorta, like in cases of retroperitoneal fibrosis, or it changes in other vessels like giant cell arteritis or temporal arteritis. Then what is actually we have two different conditions considering the aortic inflammatory lesions. We have the infectious and the non-infectious aortitis. In non-infectious aortitis, like the Takayasu and giant cell arthritis, which has been mentioned before, which have been mentioned before. Then inflammation also of the aortic wall by rheumatological disease like rheumatoid, systemic lupus, Wagner, and Bassett. But infection of the aortic wall is much rare and is caused by bacteria, viruses, or fungi. Of course, the treatment of non-infectious aortitis differs greatly from the treatment of infectious aortitis, which needs the injection or the administration of antibiotics. Then you remember this classification: aortitis, inflammation of the aortic wall; periaortitis, inflammation of the periaortic soft tissue, and both can exist in the same patient. The clinical presentation of these inflammatory lesions include back or abdominal aortic pain with fever, present in about 80% of the cases. Inflammation means that there is some fever and pain. Elevation of the erythrocyte sedimentation rate in about 85% of the patient. Systemic inflammatory symptoms, stable angina due to coronary involvement, aortic thrombosis with distal embolization, then the development of inflammatory aortic aneurysm, or the development of dissection or rupture, which are rare, then claudication pains in the upper and the lower extremities, hypertension in young patient, ureteric obstruction in cases of retroperitoneal fibrosis with hydronephrosis, and sometimes we got renal insufficiency. Then in CT, ultrasound, MRI, and PET scan will show the presence of a periaortic soft tissue mass or soft tissue sheet, which indicates the presence of inflammation, and this will show metabolic activity on PET scan. One of the important risk factors for inflammatory aortic lesions is the smoking. Then the treatment will indicate, number one, stop smoking, and number two, the administration of corticosteroids, and then we may use, after the regression of the inflammatory condition, then we'll judge the interventional or the surgical management guided by the clinical condition. IgG4 periaortitis or periarthritis means an autoimmune inflammatory condition with the development of periaortic sheet of inflammatory soft tissue. Then in this particular disease, hypertension and smoking are not risk factors. This disease is diagnosed by the following criteria. Number one is increased IgG4 serum level above 135 milligram. The normal level of IgG4 is less than 10 milligram. Then the characteristic response to steroids and the presence of other IgG4 related diseases like autoimmune pancreatitis and other conditions in the kidney or gallbladder, for example. Then sometimes you may get biopsy from the inflammatory tissue, and in this biopsy you will see IgG4 plasma cells and the severe interstitial fibrosis. Then IgG4 related periaortitis is classified into 5 types, and these types are involvement of the infrarenal aorta, the infrarenal aorta and the iliac vessels, the arch and the infrarenal and iliac, the iliac only, and the type 5 other involvement rather than these 4 types. Then here you can see the periaortic inflammation and the extension to the left common iliac artery, and the response to corticosteroids is very important, where you see this big soft tissue sheet around the aorta and the common iliac arteries, and after corticosteroid therapy you got considerable regression of these inflammatory changes. And another case by CT and MRI, and then this is diffusion weighted image. You got diffusion restriction in the inflammatory sheet around the aorta, and this is the follow-up after steroid therapy of 3 weeks steroid therapy, and you got significant regression of the inflammatory changes. Also, the aortitis means that you got inflammation of the aortic wall, and this will lead to one of two: either narrowing of the vessel or weakness of the vessel wall and the development of inflammatory aneurysm. And this is the case, and even in cases of inflammatory aneurysm due to IgG4 related periaortitis will respond to steroid therapy, and you got significant regression in the aneurysm size. Then we came to the retroperitoneal fibrosis, which is considered one of the periaortitis diseases, where you got a sheet of soft tissue shadow surrounding the aorta and entangling the ureters. And in the previous days, we used to diagnose retroperitoneal fibrosis from the intravenous urography, where you got medial deviation of the ureters and the proximal back pressure changes on both kidneys. The IgG-related periaortitis are non-stenotic masses with a regular margin, and in these cases, about 20% of patients with autoimmune pancreatitis may have retroperitoneal fibrosis. And other causes for retroperitoneal fibrosis are infection, radiation, drugs, trauma, and malignant tumors. If you inject contrast material, this retroperitoneal fibrosis will enhance. And here you can see the marginal calcification of a big mass in the retroperitoneal area with delayed function of both kidneys, and in the late film you got marked hydronephrotic changes with relative medial displacement of the ureters, diagnostic of retroperitoneal fibrosis. Then the CT scan is a well-known technique for the diagnosis, where you can see periaortic inflammatory mass extending sometimes around the common iliac arteries, and you got the significant regression of the disease after corticosteroid injection. Then this patient with retroperitoneal fibrosis, entangling the ureters as well, and you got some perinephric fluid collection representing a urinoma, and the delayed film showed that the perinephric fluid collection is stained with the injected contrast material, denoting it is just a leakage of urine from the collecting system due to obstruction of the ureter by this retroperitoneal mass. Now we came to the inflammatory abdominal aortic aneurysm, and we mentioned that the weakness of the aortic wall will lead to the development of an aneurysm, which is an extreme variant of inflammatory aortic disease. At surgery for the inflammatory aortic aneurysm, you see thick aortic wall, adhesions to the adjacent organs, marked perianeurysmal and retroperitoneal fibrosis. And then this is quite different from the aneurysm, which is not related to inflammation. Inflammatory aneurysms account for about 7% of all aortic abdominal aneurysms, and they predominantly seen in males, and the age of onset is 5 to 10 years earlier than the non-inflammatory aneurysms. Smoking is also one of the major risk factors in this particular disease. Then we have a triad of thickened aneurysmal wall, extensive perianeurysmal fibrosis, perianeurysmal adhesions. And the incidence in males is very high compared to that in females, and the mean age of presentation is about 65 years. In few cases, retroperitoneal fibrosis is secondary to metastatic disease from lymphoma, sarcoid, or carcinoid. Then this is a big aortic aneurysm, and you may be able to see some calcification of the wall, and you also may be able to see a soft tissue shadow that is present around the aorta outside the site of calcification, denoting the presence of inflammation, and this aneurysm is due to and is classified as an inflammatory abdominal aortic aneurysm. Then we came to the infected aortic aneurysm, which this name is preferred than mycotic aneurysm, because mycotic aneurysm indicates that the infective organism is fungus, while most of the aneurysms are not the sequelae of fungal infection, but maybe due to bacterial infection like Staph aureus, Salmonella, or Pneumococcus, and even sometimes you got aneurysm due to viruses. Then you say infected aneurysm rather than mycotic aneurysm. Then how can you diagnose the presence of infected aneurysm, and you separate this from the inflammatory aortic aneurysm? Then there are some criteria, and these criteria are seen in the in the images, and also are present in the clinical and the clinical signs and symptoms. Number one is rapid enlargement. Number two, metabolically active aneurysmal wall thickening. Number three, blurred periaortic soft tissue structures. Number four, contrast uptake of the aortic wall or the presence of periaortic abscesses. And this is evident here, where you can see two loculi of pus with marginal enhancement representing abscesses, and also if you see air or gas in the thrombus. The surgical mortality is higher than the treatment of conventional aneurysms. The endovascular repair as well as long-term antibiotic treatment may be curative. And if you look here and you see that there is the wall of the true lumen of the aneurysm, and you got air within the thrombus. And one may say that why you do not say that this aneurysm is penetrating into the bowel and developing an aortoenteric fistula, and this air is coming from the bowel, not from infection. I will say that if an aneurysm is connected to the bowel, then the pressure in the aneurysm is much higher than that in the bowel, and the direction of flow will be from the aorta to the bowel, not from the bowel to the aneurysm. Then if you see air or gas in the wall of the aorta or in the thrombus itself, associated with perianeurysmal fat stranding and inflammatory soft tissue, you know that you are dealing with infective aortic aneurysm. Then finally, we came to the peripheral arterial disease, which we see every now and then in our clinical practice. The prevalence of peripheral arterial disease is about 12%, and smoking is a very important risk factor for this. Also, arteriosclerosis is the main cause of occlusive arterial disease in patients more than 40 years of age, and the high incidence is seen between the 6th and 7th decade of life. The risk factors are obesity, diabetes, smoking, advanced age, hypertension, and hypercholesterolemia. Then this is just a review of the anatomy of the lower limb arteries. You know that at the level of the inguinal ligament, you got the common femoral artery below the level. Then the common femoral artery will divide into the deep femoral and the superficial femoral artery, which will continue until an area that is known as the adductor canal, where the femoral artery will be transformed into the popliteal artery. And the site of the adductor canal is just proximal to the site where the artery crosses the shaft of the femur. Then the popliteal artery will give the anterior tibial artery, which has a characteristic shoulder, as you can see here. And this anterior tibial artery will continue as the dorsalis pedis artery. After that, the artery, the popliteal artery, after giving the anterior tibial, will be transformed into the tibio-peroneal tract or trunk. The tibio-peroneal trunk will give two branches, the peroneal artery and the posterior tibial artery, which will continue as the plantar artery in the sole of the foot. There are many classifications for the types of the lesions seen in arteriosclerotic disease, and actually we do not see this, we do not use this classification in our reports, but I included in the literature for anyone who would like to stick for this classification system. Then we can diagnose the lesions by all the imaging techniques, including even the plain film. The plain film will show the presence of a atheromatous calcification of the affected vessels, and it may show some ectasia or aneurysmal dilatation. And ultrasound and Doppler are one of the diagnostic tools that are very important for assessment of peripheral arterial disease. Of course, CT angiography is one of the commonly used imaging techniques for diagnosis of arteriosclerotic disease of the limbs. Sometimes we may use MRI, especially in patients who have problems for injection of contrast material, but you should know that the resolution of MRI is much less than that of CT. Of course, MRI is free of the risk of radiation compared to the CT scan, and many times before that the great advantages in the field of CT angiography, we used the digital subtraction angiography for assessment of the peripheral arterial system. Then this is just to see the peripheral lower limb arteries by MRI without contrast injection and with contrast injection. Actually, the images obtained after contrast injection are much more better than those obtained without contrast injection. But these actually are very, very good images compared to those obtained during the regular practice. Then we came to the traumatic arterial injuries, where penetrating injuries may result in some damage of the peripheral arteries. And there are two main pathologies: the development of pseudo aneurysm, and sometimes you got rupture or occlusion of the vessel. And also you may got communication or connection between the artery and the adjacent vein with the development of traumatic arteriovenous fistula. For the diagnosis of this, we may have the CT scan, the MRI, and the ultrasound. In my opinion, ultrasound is the best way for evaluation. But for surgeons, they are familiar with CT. They need images to see the actual site of the lesion and the associated abnormalities. And CT is performed by introduction of an 18 gauge venous catheter in antecubital vein, injection of about 150 milliliter non-ionic contrast media with a rate of 5 millimeter per second, and the scanning, the delay of the scan is about 25 seconds for the upper limb and 50 seconds for the lower limb. Then you got reconstruction of the images, and you look for the abnormalities. One of the big obstacles in the CT angiography is the presence of retained metallic foreign bodies. And these foreign bodies will produce artifacts, as you can see here, hindering accurate evaluation of the site of injury. Arteriovenous fistula is a normal communication between the artery and vein, and is usually one of two, either acquired or congenital. The acquired is just like the arteriovenous fistula, which is surgically induced for hemodialysis, or the acquired arteriovenous fistula secondary to trauma or surgery. Then about 50% of traumatic arteriovenous fistulas occur in the lower limbs, while about 50% of them are related to the femoral vessels, and 15 are related to the popliteal vessels. Then you may need to reconstruct the images, and sometimes the newer scanners have the software which is artifact free, that can deal with these artifacts, enabling much more better evaluation of the site of injury. The fistula may present by a pulse-style hematoma or bruit or thrill, and machinery murmur is noted in most of the cases. And arteriovenous fistula that is present since long time may result in hemihypertrophy of the musculature of the limb where the fistula is present. Then you may get pseudoaneurysms, and which sometimes simulate abscesses or ganglion cysts, for example. And these are the CT angiographic signs of arterial injury. Number one, active contrast extravasation, the formation of pseudoaneurysm, abrupt narrowing of the artery, and loss of pacification of the arterial segment at the site of injury and the presence of arteriovenous fistula. And this is an arteriovenous fistula caused by gunshot injury 15 years earlier, and you got significant hypertrophy of the limb compared to the healthy one, with edematous and fibrotic changes in the subcutaneous fat. And this is the site of the fistula between the popliteal artery and the popliteal vein. Then you may use the reconstructive capabilities of CT, and you do 3D reconstruction and 2D reconstruction to see the actual site of communication between the artery and vein. And this is another example where you got in a connection between the popliteal artery and the vein, and this is after surgery where you occlude the site of the fistula. There's still remaining some dilatation of the arterial limb in the arteries in the right lower limb, but you got significant regression of the limb sign and inflammatory changes. Traumatic fistulas are associated with direct arterial trauma, which is usually sometimes the sequelae of fractures or a penetrating injury. You remember one of the sites of arteriovenous fistula is the carotid cavernous fistula, which can be spontaneous and can be the sequelae of trauma. And we have discussed this type of fistula in details in the head and neck lectures. Then the traumatic arteriovenous fistula are differentiated from a iatrogenic fistula, the congenital fistula, and other types of fistula are considered rare. There are two main types, you remember, the acquired and the congenital types of arteriovenous fistula. The diagnosis is performed by all the available imaging techniques, including ultrasound, CT, MRI, and digital subtraction angiography. And this is a good example of a patient with multiple good gunshot wounds to the right groin, presented 14 years later by worsening right groin swelling and pulsatile sensation. Then you got the communication between the femoral artery and the vein with huge dilatation and the multiple collaterals. You see the dilated ectatic common iliac artery as well. And this is a gunshot wound to the left side 40 years ago, presented by heart failure. And you can see the communication between the femoral artery and the vein, which with significant dilatation of both the artery and the vein. Traumatic arteriovenous fistulae may result in chronic venous insufficiency and venous hypertension with skin varicosities and ulcerations, high cardiac output failure, arterial insufficiency, and sometimes hemorrhage. Thank you very much.